my pleasure to welcome everyone to the Policy Roundtable on India's healthcare systems. The topic couldn't be more timely given the very ambitious announcements in the most recent budget for national health insurance coverage to cover 500 million Indians. As with many of these complex things, the announcements have been made, but the details are still in progress, as we say. And we're very pleased to have a very distinguished panel here for this. We have representing the policy side of this, Alok Kumar from the NITI Aayog, who's advisor health and social policy. And we have two very, very distinguished academics who worked on health issues in India for a very long time. So without further ado, let me just open up the floor and structure this conversation with inviting Alokji to first talk just about the vision and what is the plan with regard to implementing this very ambitious healthcare program, and then call on Jeff and Abhijit. I don't know in which order you want to go. Like, Jeff, do you want to go, or I'll get Abhijit in first to maybe talk. Sorry.
Then I'll just say I agree.
I agree. Okay. So, and then we'll open up the floor to questions. So, Alok.
Thank you. Is this on? Thank you. Thank you, Karthik. And good afternoon to all of you. So I've been asked by Karthik to speak on the initiatives of the government. So we have heard the Ayushman Bharat program, and that is fairly well known. So I will spend some time on it, but I would also like to kind of place for your consideration some other areas that we have tried to work on, primarily in the area of regulations. And we would also like to then share somewhat of a broader vision, because we understand that while the announcement of the programs could initiate the changes in the desired direction, there is a long distance to cover, and a good, well-functioning health system is still somewhat in the more distant future. I can't see that it is happening in 1 year or 2 years. So it will be a more, it will take us some time. Many countries have taken centuries to do it. We don't want to prolong it that long, but at least a decade, if not earlier, if not later. So that is the kind of vision that we have. So coming back to the Ayushman Bharat, but before Ayushman Bharat, a kind of a sketch of the Indian health system. So organization is mixed, predominantly private. Government is trying to strengthen the public health system, but by and large the shares still continue to be largely dominated by the private providers. In terms of the financing, again, largely out of pocket. About 64% of the expenditure is out of pocket. Of the total spending, government is about 30%, remaining 70% coming from private sources. And organization of finances into risk pools or sickness funds or any such like is very low. There are a set of rich people, or probably the people who are in organized employment. I should not say rich, but people who are in organized employment, they have private insurances or government provided insurance, but largely the large masses are either dependent on their own savings to access health services, or are dependent upon the government services which are available at low cost or zero cost at some cases, but access to them is a challenge owing to a variety of reasons, some of which may relate to the delivery of services or the way we organize the delivery of services through the public sector. And some of it also relates to their inability of the citizens to enforce accountability on the part of the providers. So this is the milieu in which we function. Regulations are pretty weak. So we have Clinical Services Establishment Act, which purportedly supposes to regulate the private sector. But many of the states have not even, so this is a central model legislation which the states are supposed to follow, supposed to enact their own versions. Some states have done so, but large states have still not enacted those, or even when enacted, the enforcement mechanisms are fairly weak at this point in time. So this is the broad milieu in which we are functioning. And there are two strands of thought insofar as the future of the health system is. One strand of thought is to kind of expand public services. And you can see the NHM, National Health Mission, which was the flagship mission scheme on health for the last about decade or so, maybe more, slightly more than that. And that is about strengthening the primary and the, to some extent secondary, but major primary health services. And this was largely restricted to so far on the mother and child services and on the on some infectious diseases. The large part of the non-communicable diseases, there was a very small component, but it is almost a marginal part of the whole thing. The second part is about strengthening the tertiary care, and that is what is called as the PM Swasthya Suraksha Yojana, which is about creating more All India Institute of Medical Sciences like institution, almost one in every state, strengthening of medical colleges, upgrading district hospitals into medical colleges. And the reason for this, I mean, the case for government spending on tertiary care is something, is somewhat of a debate, but the reason largely is more to do with creation of manpower, because the private sector, while they offer a load of, they offer a larger share of services, their record in terms of producing manpower which would feed into the industry is pretty low. So if you look at the doctor population ratio, specialist ratio in particular, and paramedics and nursing, you would find that we are not producing sufficient number of, so just to mention, for instance, if you look at graduates in the engineering side and graduates on the health side, it is a ratio of 22:1. That is, for every one doctor that we produce, we are producing almost 22 engineers. And therefore, we have almost a surplus of engineers, but we have a huge shortage of doctors. And if you look at the specializations, it is even worse off. So with this, and with the fact that the private sector predominates, what you find is the urban-rural skew in terms of distribution of resources is pretty skewed in favor of the urban area, of urban population, and skewed against. And it is also some, if you look at state-wise variations, that is also seen. States which have poorer health systems, poorer health outcomes tend to have lesser number of personnel. So there is something that we need to do to increase the supply. This is government's partial answer to this, but in my view, it is an insufficient step and we need to do further. And for that, we have the regulators. If you look at the councils which are regulating medical education, nursing education, dental education in India. So far it is a kind of a guild kind of a regulation, which means the doctors elect from among themselves the regulators who are supposed to regulate their profession. And not only do they regulate the ethical conduct and the adherence to treatment guidelines, they are also in charge of licensing of private medical education, which is now the major part of the education, the medical education ecosystem. With the net result, all these councils, to some extent or the other, are discredited. Many of their heads or chiefs have gone to jail. But we have not come to any satisfactory resolution despite, and at some times the parliament had to step in the government had to step in and remove these bodies through ordinances and so on and so forth, but it seems that they keep on coming back again and again because the same set of people seem to have captured the institution, and it is impossible in the current scheme of things to dislodge that lot. So one of the things which the government is trying to attempt is to streamline the legislation with respect. All these legislations are of the 50s, 60s kind of vintage. They had a utility and they served their utility, and I think it is now the need to create a new wave of institutions with a different DNA, and that is what the government is trying to attempt. Of course, we are running against these interests, so it is not very easy to get it through. But we are soldiering on manfully with the hope that maybe one day we will be able to prevail. So one of the bills is in Parliament at this point in time, and we are hoping that in the monsoon session it will see the light of the day. We'll wait and see. And if that sees the light of the day, then many other of the institutions which are similarly structured could then just follow the same template and we can go ahead. So that is insofar as the medical education and the regulatory framework to increase the supply of manpower. Because so far the MCI, etc., there is a quality-quantity kind of trade-off that needs to be made. So at this point in time, our insistence on quality with poor regulatory and enforcement mechanism has ensured that we have neither the quality nor the quantity. And therefore, we need to really come up with much more pragmatic frameworks for regulation, and which we hope that the new body, in the way we try to structure it, will try and address this. So for instance, one of the things which was tried to do was to introduce a 3-year, a practitioner with 3 years of medical training, unlike the MBBS doctors who have 5 years of training. But this was opposed tooth and nail, and eventually the Honorable so some states went ahead and did that, but eventually the Supreme Court held that till such a time as you amend the Medical Council of India to introduce these qualifications and recognize them, we will not permit those people to practice. So in effect, they are practicing in many of the government hospitals, and they are doing a heroic job. I was in one of the community health outposts in Barapeta district in Assam, which this particular village was in the middle of Brahmaputra, and this guy has done about 200 deliveries over the last 1 year without a single fatality. I think it is heroic, but the Medical Council of India still doesn't, and the IMA still doesn't, they refuse to recognize that these guys have a right to practice. So one of the things which we have introduced in this particular legislation is what is called as a mid-level provider, which is either nurses who have done some kind of, have had some levels of experience after doing a little bit of a bridge course, could graduate into provisioning, or we could have other streams, practitioners from other streams like Ayush, which are the alternative system of medicine. They could also potentially do this bridge course and come into mainstream practice. So this, in a sense, would try and address till such time as we sort out our regulatory mess around more medical educational institutions to partially ameliorate the problem which the rural India is facing. Now, insofar as the Ayushman Bharat is concerned, it is again the same strand of thought. We are looking at two strands, one strengthening the public sector institutions and the other strengthening and looking at purchasing services from both public and private. So on the primary care side, now we are going a step below the PHC, and that is it's called sub-center, which is currently led by an ANM, an auxiliary nurse midwife, and she is primarily looking at the vaccinations, the preventive health part, and the mother and child services. So at present, our PHCs and the sub-centers together cater to around 12 services which are restricted to the communicable side and on the mother and child services side. Now as the disease burden is almost reversed, we have now 70% of mortality on account of non-communicable diseases and trauma. So obviously there is a need now to expand the primary care covering the non-communicable disease side, and that is what Ayushman Bharat with the Health and Wellness Center, 150,000 health and wellness centers, proposes to do. It is to be established at a level of 5,000 population unit and is to be led by mid-level providers where doctors are not available, and in states where doctors are available, it may be led by a doctor. And it will be a typical kind of a general physician kind of a concept where they would try and map out population profiles, their health profiles, try and see what can be done at the early stages of the diseases, either by putting them on some kind of lifestyle changes issues, or trying to address them by medication at an early stage so that it doesn't develop into major complications. So this is the health and wellness center part. I can't say that we have figured out a model as yet. I guess we will have to look at multiple solutions, and there are a large number of promising examples that are coming up, use of AI, assisted delivery, teleconferencing models, and we are trying out 7 or 8 or 10 different models at the experimental sites, and then we will, in a sense, try to scale it up. But the minimal thing which we are looking at here is all the preventive services, screening the populations for hypertension, diabetes, cardio issues, and some cancer, early stages cancer issues. And in addition, the mother and child services, the vaccination services, and all the preventive services with respect to communicable disease still continues. So this is insofar as the health and wellness center part is concerned. Another issue that is we are trying to introduce here is, so far the public providers at least are paid for as a salary, fixed salary method, and there is therefore no incentive to overperform. Rather, there is an incentive to underperform because you get the same amount of salary independent of the number of patients you look. Except the only place where we have performance-based payment is ASHA worker, which is right at the community level, and she gets paid only on account of performance. So every payment that she gets is linked to a certain job that she performs or doesn't perform. So in the health and wellness centers, again, there is a talk about in terms of how we can incentivize payment based on performance. But the measurement of performance is a fairly vexed issue, and therefore the IT backbone to run that system needs to be fairly robust. So we are, we have just, NITI Aayog has just come out with a consultation paper on the IT framework which could run the health system, and it is up for consultation. I think 1st August, we are expecting comments on that till 1st August, and then we'll go ahead and kind of look at it. The other part of the equation is the insurance cover, which for secondary and tertiary treatments for 500 million people. So the idea there is to empanel a set of hospitals which could be both, all the public sectors are deemed empaneled, public sector hospitals are deemed empaneled, and the private sectors, they will have to follow a certain a process for empanelment. And the idea is that any patient, any of these people who are covered under the scheme, and they are deemed automatically enrolled. So unlike the Swasthya Bima Yojana, every year they don't have to get a new card made. This is, once you are enrolled, we are informing them of how they are, of whether they are enrolled through meetings at the village level. And any person who is enrolled, if he or she has an Aadhaar number, he or she can come to the, so tell me when.
Yeah, you can take another 4 minutes.
Another?
Another 4 minutes.
Another 4 minutes. No, I will take less than that. So the idea is to, so they are self-enrolled, and as soon as they reach, if they don't have the Aadhaar card, at the first instance, they will have to get an Aadhaar card made. After that, it is just about coming, authenticating your identity, and a set of 1,364 diseases are covered at this point in time. The package rates are fixed. You just go undergo a cashless treatment, you go home, and either the government or the insurance company settles the claim. Now, the model for the claim settlement agency is left to the states. Some of the states are opting for a trust model, which means the state itself take on all the risk, financial risk with respect to the claim settlements, and they can in turn outsource or use the services of a TPA to settle, because many of the states may not have the capacity to implement or settle the volume of claims that we feel would likely to be generated by this exercise. And some other states are looking at an insurance model, which means that they would contract out this whole service to an insurance company to handle the claims and settle the hospital bills. And in turn, the state will pay a particular premium based on a per family basis to that insurance company. Our assessment is that on 15th of August, there or thereabouts, we should launch this scheme. I don't say that we will be able to launch the scheme at the national scale in one go, but my own assessment is 4 or 5 states we would be able to launch. And by the end of this year, we should be able to reach 15 to 20. That is our assessment. But the preparatory work, the capacity building work at the state level, the software which will run, that will be the critical part. So we had, because of various states trying these schemes, we had some experience in Tamil Nadu, in Maharashtra, in Rajasthan, and in Karnataka of running those schemes. So what we have done in the first go, because of the political mandate to launch the scheme fast, we have taken the Andhra/Telangana software and we have configured it, and that part is more or less done. Pilot runs are happening at this point in time as I speak, and we are confident that 15th August we should be able to roll some of that out. I think I will like to end at this point in time, and maybe we can, Yes.
Perfect. Thanks so much. I'll turn the floor over to Professor Banerjee.
Thank you. Thank you for organizing this event to NCAER, and thank you for Alok for that really nice summary. I read the newspapers often with bafflement, and this gave me far more information that I've been able to glean by reading any number of newspaper articles. I thought that instead of directly responding to what you said, I wanted to highlight one other, I think, set of issues that the government needs to think about. I know it's thinking about it, in fact, and that's the set of issues about, on the for the demand side of health. And I want to highlight the issues about nutrition, immunization, NCDs, and the choice of healthcare. I think these are 4 issues that are in any satisfactory resolution of this will depend on having, I think, effective understanding of these issues. And so let me spend a little time on it. I think the healthcare, the choice of healthcare part, probably both Karthik and Jeff know more about it than I do, so I'm going to leave it to them. But I'll try and say something about the other ones, and then maybe I can come back. So on nutrition, I think one thing that's quite clear, I think, we've been actually trying to do this for many years, trying to change nutritional practices. I think the first randomized control trial we did this must have been, 2002 or 3 in Rajasthan so 15 years ago, on trying to get people to have fortified atta. And this was the issue there in Rajasthan, is that a lot of the grains are self-produced, and therefore the grains directly get brought to a mill, milled and taken home. How do you fortify that? So we had provided the mills, every village mill or some random sample of village mills with fortificant, which they could basically free, mix into the atta. And we had done all kinds of campaigns trying to get people to be interested in it. And you see both at the beginning, about 60% of the households used this, and you see immediate drop. So it was fortified with iron and I guess folic acid, so that to deal with anemia, and you see an immediate, those of you don't work on Indian health may not know, India is kind of the world capital of anemia. We really are a kind of one of the things in which we can really be called the champions. And so male anemia in the Rajasthan population was 30%. 30% of adult males were anemic. And anemic not by the standard, the global standards, by a standard we had set of 11 rather than 13. So this is well known. So, but after about 4 months, essentially it fell off. There was the mill owners were not so keen to do this. It took another 40 seconds for them to do it, and therefore they were not keen to do it. They stopped doing it, nobody complained, the whole thing died. Despite there being very clear effects on anemia, etc., immediately. We've had the same experience we worked with double fortified salt, again iron and folic acid fortified salt, and also fortified iodized salt in Bihar more recently, still 6-7 years ago. Another experiment, it was given away to people to get them to use it. Even when it's given away, people didn't take it. There was some rumor that it's going to turn your food black, and they immediately dropped it. So, and I'll tell you a little bit the good news from there at the end, but basically it was very hard to get it. And again, when you give it away, some fraction of the families, 30% of them took it, and as a result, you see effects on the anemia of adolescent girls, which is the obvious target group for any such intervention. And so you do see it, but it goes away pretty fast since people stop buying it. I mean, this is a problem that sort of is not just to do with anemia. There's an intervention in Tamil Nadu of micronutrients in schools. No, not in Tamil Nadu, Odisha of micronutrients in schools. And again, you have the same record, which is that it's like pulling teeth. You can get the schools to get the schools to do it. They put a huge amount of effort into it. The schools started mixing the micronutrients into the school meal. As a result, they stopped giving school meals. Because it was too much work. So, somehow the whole system really doesn't believe that this is important. And so, you try to get anyone to do it, they think that, well, other priorities are more important, and therefore it never really sticks. And that's an experience from other countries. I mean, this is not just the Indian experience. Anytime any health good gets priced over, goes from zero to some positive price, the demand crashes, and this is known. So it's something that I think we need to think about. And the same sort of issue arises with immunization. So immunization, again, interesting, we did some work on immunization in Rajasthan, again, many years ago, and we've been now doing similar work in Haryana. And one of the things that became very clear from that work is that while the supply system is very important, where if there is no way to get immunized, people can't get immunized. Even when they can get immunized, the immunization, demand for immunization is weak. Weak in a very specific sense, because it's not that people don't get their first shots. The first shot is pretty high. The second shot is also high. the third shot falls off. By that time, the child is over a year old, and the fourth and fifth shots are down to, 6% was the number we had in Rajasthan. Complete immunization, 5 shots. So you have a very clear pattern. It's not that people are against it, but it's just not compelling enough to make them remember that over a period of 2 years, I have to take the child to this place and get the child complete this whole cycle. And that's a problem that I think has been identified, but it's one that keeps coming back. And you can improve the supply, but if there isn't a demand for these things, then it's not. You'll have to think of ways of dealing with the demand issue. The similar issue arises with NCDs. I mean, getting people to test themselves, free testing. People don't take advantage of it. There's a nice experiment in Tamil Nadu now where they give people a small incentive for walking, and they measure it using pedometers. And you see both health effects and increase in walking, but it's an extremely elaborate intervention in the sense that you have to be measuring how much they walked using a pedometer and then giving them a reward, sending it to the cell phone. It's a whole thing, and then you see some effects, but not enormous. And in some sense, I'm still surprised by how hard it is to get this. And with healthcare, maybe Karthik or Jeff will add to that. You have the same problem, which is, you try to tell people, ask people why you're going to this guy who has no medical qualifications whatsoever, and that's many people, most people in fact, in the health system, and you don't, and the answer is, he works for me just fine. So there's some skepticism about kind of maybe the elite view of what healthcare delivery is. And that I think that's the same problem, which is that people don't believe what you're telling them is that this is what you need to do, and they don't believe it. The two reactions two ways you can deal with this. One is, a much more, I think in some cases, for example, I think the government has now come up with a policy which I think is potentially important of fortifying rice that they're going to give in PDS. And that's the advantage of that is that that's not a choice. You don't get to choose it. The disadvantage is that might, unless that's done well, and it's very hard to do because it should not look like things that melt and make the rice, change the texture of the rice. And we've been actually working with FSSI and the Tamil Nadu government to think about exactly what fortificants will work. And there is some, it took a long time to figure out a fortificant that's stable enough to not make the rice change the texture of the rice. And so I think the government, I think this is a good idea because I think it has the advantage of making the demand side much more mechanical. This has a downside that you might get political protests unless you figure out a way to make it look like normal rice. And I think this is something to think about. Similar things, I mean, you could in principle, I would say for immunization, I don't see why there isn't a national policy of requiring immunization for example, taking your class 10 exam or something. You cannot take it unless you have full immunization certificate. This is what the US has exactly this. You can't get into public schools. And this doesn't seem to me to be, now that everybody essentially tries to get to the 10th grade exam, it doesn't seem to be an unreasonable thing to do, to just require. This is a public good. It's not I see why it's not privately people don't want to get immunized. Publicly, it's a useful thing to do. That's sort of one line of thought. The other line of thought, which is what I'm finished on, is trying to change preferences. So go back to Bihar, where remember they didn't want to have the double fortified salt. So one of the experiments we did is we made a sitcom, and the sitcom was called Lahu Mange Loha. Your blood is thirsty for iron. And it was we wrote the script, we made a sitcom, we showed the sitcom. 2 years later, only people who consume iron they are fortified salt are the people who saw the sitcom. It's a only durable effect on the whole program 2 years later is people who saw the sitcom. We've now done we work with MTV in Nigeria to show a set of, I guess these are not soap opera called Shuga to young men and women focusing on HIV mostly. And you see big effects on every marker of biomarkers, everything. So I think changing preferences is possible. It needs to be an avenue that needs to be explored. So I'll finish there.
Thanks, Abhijit. And I'll turn it over to Jeff, and then I guess I'm kind of I've been implicated as a quasi-panelist, so I'll say a few things after Jeff before turning over. So, Jeff.
Is this working? Karthik, I want to come back to one thing that Abhijit said at the end. So 30 seconds before you want me to stop, tell me and I'll come back to public goods.
15 minutes, yeah. Take it.
Oh, okay. I guess I'm going to talk mostly about curative care since Abhijit was talking about more public interventions.
Jeff, the mic.
Too far, too close?
Too far, I think.
Okay. Okay. So one of the things I think as we look at the expansion of two large programs into much larger programs is I really would like it if the Indian government watched what it was doing or measure something. A lot of these seem to be fire, aim, ready. That is, we declare victory and expand enormously without having any idea whether the thing that came before had any effect. There's two big programs for which I think I can apply this observation. One was the NRHM turning into the National Rural Health Mission, turning into the National Health Mission, and the other one is, I don't know what you call the 5 lakh thing. What's the 5 lakh insurance?
Ayushman Bharat.
Fine, yeah, from RSBY. In neither case, NRHM or RSBY, do we have any idea what happened? We might know how much money was spent or something like that, but there was no measurement of anything related to health or financial protection in the insurance case or whether or anything. So I'm reminded, I was here summer, it must have been 2013, I was up at Delhi School, I think I was visiting Rohini, and she comes by and says, hey, you should come, and there's this big celebration for the success of the National Rural Health Mission. I said, okay, that sounds intriguing. I wonder what it is that they're using as a measure of success. Since I had been here, I was working at the World Bank in the Delhi office in 2005, and we were sort of suggesting maybe there should be a baseline of what does health look like? Where do people go when they get sick? What I thought was being very simple things. They said, don't worry about it. The National Family Health Survey is going to do it, which it absolutely does not. They went ahead with the National Rural Health Mission. In 2013, I go to this celebration of great success. One speaker was the Secretary of Health. One speaker was the erstwhile Planning Commission health person. I'm not going to name names. And then there was a researcher who was looking at, I'm not sure what data that he was looking at, but he was looking at something. There was 3 things that the National Rural Health Mission did. We spent more money. We hired more workers. We increased the capacity of the states. Oh, well, that one I thought was kind of interesting because I'm kind of interested in the decentralization, 73rd, 74th Amendment, how it's working out. What they meant by increasing the capacity of the states was we got them to spend more money and we got them to hire more workers. Now, in a group of economists, you might say, oh, they increased the costs and there wasn't one single word about one child's life being saved because they had absolutely no way of figuring out whether there was any health effect of this at all. And then this was used as, so we would say, oh, very good, you've proved to us that you've taken money from whoever the marginal taxpayer is, who we don't know what that is, given it to doctors, and we have no idea what happened after that. And that was enough success to expand to urban areas where there's lots of substitution with the private sector, so an odd place to expand it. Okay, one thing that we might have looked at in 2005 was precisely the kind of things that were actually important for health policy and not just the National Family Health Survey, which is 95% about family planning and 2 questions about health. Coming to the current problem is RSBY, the insurance program below poverty line, up to 30,000 rupees, was that? Okay, here it was like chaos because every state had its own little version and nobody actually measured things that were important. What's important in insurance markets? There's 2. Well, one is these are big expenditures that people need to be protected from for financial reasons. They might go to the hospital anyway, but borrow from friends, family, whatnot, and be in debt for a long time. That's something we're trying to protect against. You know, there was a utility function, and there's the insurance premium that you might like to pay. We might like to have some notion of how much that is. We never had any information about what people did when there was some kind of shock. One would be how badly is their financial situation compromised. The other one is there might be a bunch of people who the prospective bill is so high that they actually forewent treatment and they either died, that we would probably measure, but we wouldn't know why, or they would be sick for a very long time, they would be in very bad health or incapacitated. And that's the kind of thing that would happen if you did not do the hospital procedure that you could not afford. But we have no idea how many people were in either of these categories because nobody measured it. They said that it would be, actually I have no, the individual states didn't do these analyses and the central government didn't do these analyses either. So now there's a lot of studies going on about what RSBY did, and a lot of it's very confusing, and it doesn't really, I haven't seen anything that's convincing at all. So it's really bizarre to see us expanding something where the major structure of the health sector and the payment structure has not been changed at all, going from 30,000 to 5 lakh, which strikes me as a really risky public finance kind of issue, and it's based on very little precedent. So at least starting now, if we could have some, if the Ministry of Health and Family Welfare could think through what is it that they actually want to know, what is it that we really think is important, and design an instrument to have some sense of what the country looks like as far as its actual health conditions is concerned, would be a really good thing. It should have been done in 2005. We might as well start. Now. That's one. One of the what I think is a good direction to be going to is worrying about catastrophic health expenditures. I've always thought that the emphasis on primary health care for all of it since the Borer Commission in 1946, focusing on primary health care was the wrong way to go. The major market failures being the pure public goods, which we still don't have under our, this is the 30 seconds at the end, which I'll stick in now. You should go to the Najafgarh Canal. I was there last week, and take a look at what that looks like and figure out why on earth are we spending money on doctors who don't show up frequently and who don't do much once they're there, and we're not cleaning up stuff that's obviously dangerous to to children. And that, even the trash, is of secondary value, of importance to the sanitation. And we're not even starting on that kind of stuff. The other major market failure that I see in the health sector worldwide is insurance markets fail all the time for the usual reasons of adverse selection, moral hazard, blah, 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 blah. So it's really expensive care that's a serious problem, and not necessarily these 50 rupee problems, even if they go on for a long time. It's a lot of 50 rupee problems to come up with one single hospital stay for which people need protection. So I'm glad that we're worrying about catastrophic care going forward. However, every single country has to worry about how to pay doctors for such large expenditures. Everybody, if it wasn't for the United States being a bizarre outlier, which actually looks a lot like India, every country would be complaining about their own health system because it's a really hard balance, the incentive to the doctor versus to do too much or to do too little, depending on how you pay. Most countries would be complaining if they didn't say, well, at least we're not the United States. But the current program might take us down the road towards a United States system, which is an enormous amount of money being put on the table, and I am very skeptical that the regulatory structure in India would be anywhere up to managing whether this money is spent well or not. The financial sector might have some leverage on the regulation side, but regulating individual doctors in their private clinic, that's going to be way beyond government's capacity. So I'm a little skeptical of, even though the market failure is in insurance, I'm not sure the solution might include insurance, but I'm not sure that the solution really is insurance. This is one case where I think making sure our hospitals worked reasonably well, possibly to be a competitive force against the private sector. If there was an actual credible public sector that people could go to, these very enormous bills that I keep hearing about in private sector might be modified. But since there's no credible alternative, we get, for some reason, everything costs 2 lakh. It seems like ingrown toenails, open heart surgery, it all seems, everybody mentions 2 lakhs. Anyway. But since there is no alternative to the private sector for such serious things, because we've emphasized primary health care for so long, people are stuck with the private system. Just pouring extra money into an incredibly broken system does not seem to be the best way forward. So I would actually look at regulation if you can do it, but I think that's pretty hard. But I also think making better hospitals. Visited Patna Hospital last year. I'm not a doctor, but I'm pretty sure that the things that you put intravenous bags on should not be rusty and dripping with water. So if we could improve some of them, that would be good. So it wouldn't be direct regulation, but it would be increasing competition as a way to do it. In general, we'd have no idea how the market for hospital care works. So one step above coming up with basic data would be trying to think through what is the market mechanism for expensive care, and just trying to understand what that is and where the public sector might intervene. The other thing about the 5 lakh that's kind of disturbing, maybe I misunderstood what I read in the papers, is this is also dependent on the BPL card? Where did the 500 million people come from?
So they come from a set of the census which was conducted in 2015-16 and SECs.
Oh, okay.
Socioeconomic class census.
I've been doing this weird project, which I'll love to talk about some other time. But before you get to the lowest 500 million, you have a bunch of people who might be able to pay for hospital care, 6%, 5% of the population. And then everybody in between is not all that rich. That is, 80% is below like $5 a day if you want to make one of those standard comparisons. So how you would leapfrog all of these, okay, I can do that. How you would leapfrog all of these people who also really need protection against 2 lakh hospital stay and give poorer people 5 lakh and not give it to the people in between seems not only just not politically feasible, but kind of just unfair. And something that we should worry about. There's one thing I would like to concern myself on this emphasis of NCD is, so the previous presentation went through, you should equate marginal cost to marginal social value, something I thought when they were saying that is, we would all know that, right? But on the whether or not NCDs are a really high priority, it's not that it is now the largest part of the disease. The issue is still, what can you do about it? And I still see sanitation, water supply, vector control, solid waste management, all the things that governments absolutely have to do come first, even if it is only 40% instead of 60% of the problem.
Thanks, Jeff. I'm just going to try to, I'll time myself and take not more than 10 minutes, since the speakers got 20 and 15. So let me just lay out a few key principles. I think some of this have already been discussed, especially by Jeff, but I think it's useful since, again, we have probably in the policy establishment one of the people who I know who makes the most effort to reach out to academics and kind of, try to at least capture some of the evidence. So I think just the first few key principles, I think one, and Jeff has said, but it's important enough that every economist should just keep repeating this, that I think the most basic thing the government always forgets is the distinction between pure public goods and publicly provided private goods, right? And so most of what the government spends its time doing are things that it considers public goods, but are in fact private goods. So whether it's curative health or whether it's PDS or whether it's education, whereas kind of just Econ 101, the pure public goods would be the public health, would be the sanitation, would be, So I cannot emphasize Jeff's point enough that to the extent that there's limited resources, that's where we go first, and NCDs would come way down that list. Just for, even though it may affect more people. So let me then just kind of lay out a few other key principles, which is now conditional on the fact that basic economics is unfortunately confronted with the logic of what Abhijit mentioned, which is for good or for bad, the demand for preventative stuff just seems to be incredibly low. And so to the extent that in a democracy, politicians respond to what people respond to, and people respond, all of us, we don't exercise enough, and we'll only go to the doctor, when things are a crisis. So, the politicians respond to what the voters want, and so you can't kind of blame them for that. So conditional on that, given that we've decided at some political level to pay a fair bit of priority to curative services, can we still improve that with some of what we've learned in the past 15 years? And I think the divorce here from evidence and policy is just so staggering, right? That it's just really worthwhile reiterating some of these core principles of what we've learned, starting from 2003, the WDR that, Shanta and Shekhar and others played a role in, and where I cut my teeth as a field researcher, right? So let's just go through some basic facts. So we still have fundamental accountability problems in the public healthcare system, with absence rates of about 40% among doctors. And this is not the case that when you go to the clinic and the doctor is not there, that he's absent because he's doing some field visits, because Abhijit and team in Rajasthan very valiantly then tried to follow up those cases where they said that they were in the field, and only in 7% of those cases, did they actually find the nurse doing the outreach, the ostensibly claimed outreach, right? So at a most basic level, you're spending an insane amount, on salaries on people who are barely there. So that then gives us the next kind of elephant elephant in the room, which is all the household survey data tells us that 80% of primary care is kind of with the fee-paying private sector. So this is like out-of-pocket, people just paying, the poorest of the poor, paying out of pocket in a system that ostensibly provides free healthcare. So, and most of these private providers are unqualified. So just think about it. So we think in education, it's stark that the government spends so much money and people still go to private schools, but education market share is about 40%, in healthcare it's about 80%. So just think about how much more severe, or how much worse the quality of public provision is in that setting. So 80% of usage is in the private sector. So now, of course, people say that, oh, that's because these private, so the MCI, the qualified MBBS response to why people go to the private sector is usually one of three things. One is we don't spend enough on the public, so if we spent more on the public, you would have more. Second is that people are just, they don't know what's good for them. They want kind of immediate kind of symptomatic relief, and they will get steroids, which they won't get in the public sector. So anyway, to cut a long story short, measuring quality is very, very hard. So Jishnu, my co-author, Abhijit's co-author, Jeff's co-author, kind of the absent presence on this panel, has spent a lot of time kind of refining measurement protocols. And we did this study using fake undercover patients in Madhya Pradesh, where we did representative visits to just measure quality of healthcare on a range of metrics. And so what you see is that in a representative sample of public and private providers in rural India, the average quality is comparable, though the private guy is much less qualified, right? I mean, has almost no qualifications to speak of, but makes up for lower qualification with higher effort. So the reason the people go there is at least the guy is there, and because he doesn't get paid if he's not there, okay? Now, that is still, of course, like a very low bar, because it's not like the quality of care from these people is particularly good, right? It's just that they work hard, but they don't know much. So to isolate the effect of incentives, we then managed to hunt down like a very large fraction of public sector MBBS doctors who also have private practices. And then when you kind of send the same fake patient with the same case to the same doctor in both the public and the private sector, you see that there is significantly higher effort and quality of care in the private sector. So point of all of this is that, incentives matter. And, now of course there's the next side of it, which I'll come back to. But the point is that, marginal incentives really matter. Now let's then flip it around a little bit, which is, Ken Arrow famously said that the market breaks down for healthcare, and it's a dangerous proposition to start a policy discussion saying that Ken Arrow was wrong. But I think the subtle point here is that what we see in a setting like India is that the effort levels in the public sector are so low that the market incentives of private effort actually dominate the market costs of incentives for overtreatment. So we do see overtreatment in the private sector, but we see overtreatment in the public sector as well. So the point of all of this is just that we have now a lot of evidence, right? On systematic aspects of failure, and we still end up, for the most part, spending more money down that same channel. So again, in Jishnu's famous words, it's like this Woody Allen movie where you have two guys in a restaurant, one complaining that the food is horrible, and the second saying the portions are too small. And so what you want is larger portions of horrible food, except that it's not free, it's coming out of taxpayer dollars. So, and then the last finding from all this research, which I think is quite relevant, is what we saw in our nationwide work of measuring doctor quality with medical vignettes, is that there is incredible variation across the country in the quality of the doctor holding the same credentials. So an MBBS doctor in UP or Bihar on average had lower competence than a nurse in Tamil Nadu or Kerala. And so, there's just huge variation in what that same degree means. Now, the good news is, at least broadly, I think the directions of reform we are seeing, which Alokji has driven to a large extent, I think to the extent possible within our constrained political policy environment, tries to incorporate some of these principles. So I think the first thing, which I must kind of give you credit for, is at least having this idea of a nationwide exit exam, so that standardizes quality, so that you try to you regulate less on inputs and kind of micromanaging approvals of individual medical colleges and kind of allow an expansion of supply, but kind of do a quality control at the exit level through kind of a national exit exam. Now, of course, a lot will depend on the details, but conceptually, that is definitely a move in the right direction. I think the second realization that does seem to have permeated the policy establishment, at least in Delhi and kind of at least in the NITI Aayog, is that marginal incentives matter. I think, people on the field will widely agree that the ASHA workers are the only part of the system that seems to work, because most of their compensation is based on marginal kind of compensation for marginal effort. So number of institutional deliveries, number of immunizations. Now, of course, those things are measurable. Not every aspect of healthcare quality is easily measurable. But I think the point that incentives matter I think is hopefully now recognized enough to become front and center of the design of any healthcare system. Now, the flip side is you can obviously incentivize too much, and I think in the US, the general push is towards reducing incentives because the concern is that you have too much pay for procedures and you want to dampen that. So I think one useful way of designing a certain amount of incentives without too much is to have a capitation model, where people have to sign up for insurance providers and the public insurance payment premium follows the choice of provider, but provider compensation is muted with regard to kind of marginal compensation for doing too much. So you do have incentives at the level of signing up for a practice, which means there is a long-term reputation for quality. But if you don't have too much incentives for over-treatment, like conditional on having a patient. So it's not easy, but there are at least templates that exist along that margin, and which then gets me to my final point, which is, I think, or my second last point, the importance of public and private, right? So I think, in a sense, in the US, we have the opposite problem, which is there should be ideally a public option that disciplines the excesses of the private sector. Here, you need the opposite, which is you need more private to discipline, the slack and the sloth in the public sector. But that being said, the only thing worse than a public monopoly is a private monopoly. And these things require incredible, careful attention to market design, and these are complex issues, okay? So then get to my last point, which is, I think, sitting at the IPF, right? I think you can't help but wonder about this gap, right? Which is, you've got the work Jishnu and Jeff and others have been doing for a long time, and you've got this policy environment that just kind of moves almost independent of the depth of the quality of the research that's happening, and what can we do to bridge this a little bit more? And I think, we're starting to see, again, some positive movement in the state. So I was in Telangana 2 days ago, and I was pleased to see there's a very nice attempt by some young assistant professors to work on Health IO in India using reimbursement rates in Aayog, and then looking at the impact on the supply side. So think about, there's probably 1,000 healthcare economists in the US who produce high quality research, and you have an MBR healthcare program that aggregates all of that research, facilitates access to data, facilitates new research, and recognizes that the academic time frame is different from the policy time frame. So where policymakers need to engage more is in providing access to data and kind of engaging more with the research community to create a long-term body of work, not kind of expecting short-term answers because good research takes a long time. But on the researcher side, oops, sorry, that's me disciplining myself. But on the researcher side, I think there's a lot to be done in terms of just curating and collating what we know in policy-relevant moments. And I think at least the exchange we've had a little bit, Alok and I, in the course of the design of some of these things reflects that, but it's still just a very bare bones start. So let me stop there and just turn it around to the panel and then come back to Alok in particular. Yeah. Or do you want to respond first?
As you say.
So let's go around. Yeah, we'll go around, collect points, and then, we'll start from here. Prana?
But I have several questions, but let me confine myself to just two, and both at rather sweeping levels of generality. One is, I think both of these, in some sense, have been touched upon by Jeff in his presentation, but let me elaborate a little bit on that. One is the issue of public health. And there, I think it's very important also to study the governance structure among different states within India. Because things that are not doable, done better in other countries, I think much more feasible is what has been done within India, in some parts, not in others. I think it's very useful. So there, if I remember right, there was this study by Monica Dasgupta and a co-author comparing the public health administration, so it's really a governance issue, in Chennai, comparing with Delhi, a much richer part of India. So if I remember right, they found that I think the measure was child stunting in the slum population of Chennai. The data come in slum versus non-slum. The slum population of Chennai, child stunting measures were much better than the non-slum population of Delhi. So which to me was a striking So therefore, it is imperative to study what is it about the governance structures in these two cities which drive this strikingly different outcome in terms of public health. And if you can give us some idea about where to go in this governance issue, I think that would be very useful. Second, again, at the level of sweeping generality, is even more sweeping generality, is what is the model, ultimate model that we have in mind? As Jeff suggested, if it's ultimately we are going to this RSB now size up to the national level, and instead of 30,000 giving 5 lakhs. So essentially, are we running down the road to the US model? Then I personally regard that prospect as dreadful. But then what are the other alternatives? And there, I would like some discussion. Forget about countries which have done reasonably well in this respect, particularly single payer in terms of funding, but multiple providers, public-private. So examples would be like France, Canada, and Germany to a large extent. But forget about developed countries. I would like to know what can India learn from a neighboring country, Thailand, which is now a similar kind of more single payer for basic insurance, basic healthcare, and competitive public-private competition in provision. And Thailand did it in the just about what, about 12, 13 years back. What is it that they could do that we cannot at least partially replicate? Let me stop there.
Vijay?
I just want to follow up on Pranab's point about what is the ultimate model. I'm really confused by this because Pranab said that, if the new health scheme is just the RSBY writ large, then we are rapidly progressing towards the US model. Now, that's not my understanding of the situation at all. I thought, perhaps wrongly, you can correct me, that the RSBY model was a single payer public and private provider model. So and I think that as far as I could see, Pranab has got it wrong. But I would like elaboration of this, of this point.
What I meant in RSBY, in fact, the majority don't go to RSBY, even in the states which have adopted it. So it is a single payer, government is providing the 30,000, but majority go elsewhere. So that's the only sense I meant. At the moment it's operating, it's not single payer.
If we are talking about the ultimate, where we are headed to, so the question is whether we should be headed towards the UK system where you've got the state both, in a sense, combination of insurance and provision by the state, the North European system where we have a single payer but public and private providers, and the US system where insurance is also private, so everything is private. And I thought that we were the ultimate destination of the North European model was the right kind of model to pursue for the long run. Though, of course, it should not be confined. I mean, it would be a good idea to have large numbers of people, not just the poor, but everybody in a compulsory insurance scheme. But we are talking about the long run. So that's the model that I think we should be following. And so I'd like some clarity. Is that in fact the view of the panel, or is there some other model we should be pursuing?
I'm not seeing any other, I guess people are tired. It's a long day. I'll come down here to Ila and then we'll go to the panel, maybe take a second round and, sorry, Indira. Indira and then Ila, sorry.
A clarificatory question to the government representative. As I understand it, a key difference between RSBY and Ayushman is that RSBY only paid for inpatient treatment. It didn't pay for a routine cold or diarrhea or whatever, whereas Ayushman pays both for inpatient and outpatient care. Is my understanding correct? No? Ayushman is only for inpatient?
Yeah.
Oh, it's not for outpatient. Okay. Then in that case, Jeff, you said we don't really know what happened to RSBY because we have no data. You're absolutely right on that. But from a lot of activists, I have come to learn that a key problem with RSBY was the incentive that gave for doctors to recommend inpatient care for something that could have been done through the outpatient route. And what was far worse, there were a lot of fraudulent appendectomies, fraudulent not in the sense that the operation wasn't performed, but that the patient didn't actually need the operation. So a lot of these were performed. So some years later, after I learned this, I attended a talk given by Anil Swaroop, who was the architect of the RSBY. And I asked this question, how did this happen? And his response was that the kind of back office auditing which could have caught these kinds of misdemeanors didn't happen because funding for it was not forthcoming from the Planning Commission. So there is a very real danger in these systems that the kinds of modular financing that you need, for instance, for back office auditing to make sure that you don't have, the system doesn't get corrupted. It's important to make sure that the entire funding package is complete and provided for budgetarily, because otherwise you'll get these kinds of things happening in the system.
Okay. First, to disagree with you, Karthik, on the NCDs. So NCDs are a rising burden, and the relationship between NCDs and public goods today is stronger than ever before. India has 14 or 12 of the most polluted cities of the world, and the risk caused by air pollution to health includes ischemic heart disease, pulmonary disease, arthritis, and many things that we don't even know about. And the list is long, and the WHO disease burden reports have been talking about some of this rising burden. So in fact, I would add to Jeff's list of vector control, water, sanitation, that today air pollution is a big killer and a rising and increasing killer. So the role of public, what we think of as pure public goods, air pollution is really gone 101 public good. So that's the first point. The second is we've been doing some work at NIPFP on trying to understand the effectiveness of insurance programs. And in that process, we studied the history of health insurance programs. What seems to be happening is just disillusionment with the existing three-tier Bhore committee system, where politicians across states, now at the center as well, but until so far across states, felt that they could not reform the three-tier system. They could not make public hospitals work. They could not get doctors to even, there are about 67% vacancies in PHCs. CHCs have a similar 70-75% vacancy. So they couldn't get doctors to even be in those jobs. Absenteeism that you've studied is over and above that. And it's that has over the years given us 44 government-funded health insurance schemes. There's not one, there's not two. There are not just RSBY, there are 44 schemes. We've written a paper documenting these schemes. And as Jeff has so correctly pointed out, not one, not even one, have outcomes been studied. So all that's happened is, we got disillusioned with the existing system, and then we said, oh, but we can't do that. But if a state government is seen like, if a chief minister is seen as giving money out to people who fall ill, and whether the hysterectomies and the operations happened, or sometimes they didn't even happen. I mean, the money was shared between the doctors and the so-called patients. So whatever happened, it was better than trying to push money under into public systems. Now that takes us to Alok's presentation about how the regulation is today very, very weak. Now you think of us going forward on these health insurance schemes, not only without studying how they have functioned and whether they have been successful in any way other than spending money, and also understanding that at the moment, the Medical Council of India has criminals in place. And one of the questions you asked was, so what can we do to improve the Medical Council of India? So that's the only regulatory body. The rest are these states are supposed to have these clinical establishment acts. Delhi, by the way, has not passed the Clinical Establishment Act. And so we are under a Shops and Establishment Act, under which hospitals and these various garages that have kidney transplants run. So what is the way forward? Now, one of the things that other countries have done is to take away the dominance of professionals of that field. So in the Medical Council of India, you have 87, 89 doctors who elect Mr. Agarwal every year, regardless of whether Mr. Agarwal is in jail or out of jail. And when he's out of jail, then they elect Mr. Agarwal's brother, Mr. Gupta. So it's, these are fake names, but it's pretty much this. And we know by now that it's pretty much this. And the same people keep coming back. So what other countries have done is to change the nature of the boards of regulatory bodies like this and make them government appointees so that the doctor capture goes away. And we know how strong this doctor capture is also from the fact that only 7 doctors have ever had their license revoked. I mean, unless the number has changed in the last few months. And since the Medical Council has been in action, surely there are more cases than that in India of doctors doing malpractice. I mean, we've enough anecdotal evidence to talk about that. So why is it that the government is so reluctant to take on this lobby, which is clearly doing things that are criminal, unethical, and we are just sitting quietly and watching this happen, rather than move on the way where, you have very few, could bring in 2 experts, 3 experts, but make it like in the case of financial sector regulators, make them government appointees and go get out of this huge, very large council which is perpetuating all the crime.
On that very cheerful note, I will turn over to Alok ji first. Sorry. Oh, please.
Yeah, I want to expand the issue of NCD a little bit. Air pollution has already been mentioned, but if you look at the best buys in NCD, it is not within the health at all. It is totally outside health, and they're equally pertinent policy issues, such as how food is regulated, transferred, and salt in the food. It is about tax on tobacco, tax on alcohol. It is about creating urban infrastructure where people can walk, exercise, have access to gyms. So, these are, you have to look at NCD from the same perspective that we did on water and sanitation and communicable diseases, for example. Otherwise, I think, if we put NCDs versus communicable diseases, I think, that sort of positioning will be a risky positioning, because the NCDs is upon us. It is a huge burden, and public policy approaches is not within the health. If you are treating diabetes, we are already lost the battle, frankly speaking. So the prevention is at a different level, and that's the argument I want to put forward. And finally, I have a question for a colleague from NITI Aayog. And that is, do we have agreement on unit costs of procedures, or is it left with the states to decide? What's the status? So thank you, and over to you, Karthik.
Thank you. So in fact, I'll just respond to one thing. I mean, I don't think I disagree with anything you said. I think my point about NCDs not being a priority is just that when NCD shows up on the policy radar, it shows up from a curative perspective. That's all. So I would have zero objections to air pollution being like a central part of healthcare policy, but I don't think it's being discussed that way. So I think it's just that when government says NCD, it will typically mean centers for dialysis, centers for diabetes, centers for this thing, and that was my only point. So let me hand over to Alok ji, and then we'll go back around the panel.
Okay, let me try and answer there are many questions, and let me clarify by saying that I am not a trained economist, so please pardon me. I will, in this room full of economists, I am probably the most illiterate person, but I will try to answer to the best of what I understand. So, to your question, sir, unit cost of procedure, I will come from the last to the first. Now, insofar as unit cost of procedures, we have a costing exercise. So, you see, one of the problems of developing a health system is that the institutions which will be driving those health systems are absent at this point in time. So, we had a ministry-led model of delivery of healthcare which concentrated on what Karthik said, 20% of outpatient, that is urban area. In rural areas, it is better, 28%. And if you look at the inpatient, it is even better. It is about 40-60. So, obsession with public sector delivery, because that was seen as my charge. What else is happening outside was not seen as my charge. And that, to my mind, has been, so one of the things which has been lacking is the government playing the role of a steward rather than a provider. So we were concentrating, and even that we didn't do a very good job of, and I think a lot of commentary has been made, and I don't want to add anything more to that. So to come back to your specific point, so what we did was we took prices for not all the procedures, but the 40 most commonly used procedures, took about 100 readings from different providers at different levels, right from the corporate level and to the way it is being provided in a district level single doctor or a 2-doctor clinic. And we took a median kind of a assessment of that. But this is the base rate. We are permitting the states to add another 10% for local labor market variation. So say if the rates in Kerala, labor rates in Kerala are slightly higher than say labor rates in West Bengal or Bihar, I'm just making it up. The local state governments could add another 10%. Then we have 3 or 4 incentive-based payment that if you are quality accredited by the NABH, the National Accreditation Board of Hospitals, you get another 10% on that basis. Then another 10% if you are located in as what we call as aspirational districts, which are the 20 worst of districts in India. So we are trying to use the payments to, kind of incentivize and another 10% if you are skilling people. According to our definition, skilling means if you are conducting DNB courses for bringing out more specialists, or if you are doing something for paramedics, certifying paramedics, etc. So we will give you another 10%. So this is how broadly so I don't say that we are, in a sense, so there is a lot of leeway for the hospitals to earn, but at the same time, I don't see that whatever level of costing we will do will satisfy the place where you and I go for our hospital, for our needs. Now, that is a model that India cannot replicate at scale. We don't have the budgetary resources to do so, and let us frankly admit it that we will not be able to provide that level of treatment to every citizen of India at this point in time. Maybe at a future date we do. So, what we are saying to them is, can we come down to general ward treatment? Most of my patients are happy sharing a ward with 4 or 5 people. I mean, as long as you do, and we look at our All India Institute of Medical Sciences, if I think it is a good idea for some of you to study that, and I can guarantee you that no hospital in world will give better value for money than my All India Institute of Medical Sciences or a PGMIR or many of the medical colleges even. It may be true that some of the primary health centers, etc., where we don't have governance mechanisms in place are not able to do that. But many of our hospitals give better value for money than, and if you look at the kind of patients they handle, 12,000 OPD per day multiplied by 365, that one institution. I mean, the amount of the inpatients, etc., which they handle, the volume which they handle, and the category of that patients they handle, and look at the infections rate, look at the readmission rates, and then you will find that you are not so badly off. So it's not good, or it may be very fashionable to do so, but not very good to tar the entire system with a single brush. So, so what we are saying is that we are happy with the general ward treatment. It is okay if we can't have the the Italian marbles on the floor. It's fine. I mean, we can handle that. I mean, if you go to the AIMS, they have all mosaic floors, but they are doing equally fine. I mean, so one of the things which we need to do is to look at to transform a high volume, high margin, low volume operation into a absolutely the reverse. That is a assembly line kind of a product with low margins, but very high volumes. The other part which we need to also look at is the organization of our health system. Now, if you look at your institutions, you have out of the 100 facilities, only 3% are which are more than 50% and 50 beds and above. There are about 12% between 10 beds and 50 beds. And 85% of our operations are single doctor maybe and less than 10 beds. Now, can you think of a 21st century system with this kind of an organization? I don't think so we are subscale and we are suboptimal, and this is not true only in the health sector, it is true of our industries, it is true, because we are doing subscale operations. Now, one way is to legislate, no, you will do this and at least you will have that many number of beds, which is the clinical service establishment mode, which will create a whole army of inspectors. We have created a same thing in the Environmental Protections Act. We have created another, and we have not done, I think we are not doing a good job on that either. So therefore, having recognized our limitations, would it be better to become a payer and try to alter behaviors, or do you want to become, a regulator and then try to? My understanding is that as a payer, you might have more leverage, and you will ensure compliance, voluntary compliance, rather than trying to artificially impose over that. So that is what we are doing at for the package cost. As far as the regulator is concerned, exactly the NMC bill says exactly what you are saying. And I think we were in touch with Ajay Shah at one point in time to understand the FSLRC, the broad regulatory setup. So it is from election to selection. That part is, it is still a doctor majority, because we don't, I mean, that's a strong lobby. So there's still a doctor majority, but we have opened up for non-doctors to be in, and there are categories like economists, consumer activists, etc., to be appointed to that commission. I think 5 out of 29. But still you will be there. And plus you will have, so I mean, in a sense, there was, the UK model is 6 and 6, equal to laypersons and to doctors, but I think that was not considered feasible and possibly difficult to pass through the parliament. But those principles, what you are saying, are all there in the NMC bill, provided they let it pass. Even, I don't know, I mean, so we are hoping that this parliament session will bring us some cheer. To the one issue which was raised was with respect to impact measurement. Yes, ideally one should have impact measurement, but how do you do an impact measurement, and a causal one at that, for a developing country like India, where multiple initiatives are happening simultaneously? I can't say, so for instance, the road building program is going on. The the sanitation program is going on. The rural development program is going on. Economy is going on at a particular rate. How do I estimate or say that this effect has been caused only because of health? And the only way to do it is what Abhijit is his bread and butter, RCT. Now, do we have the patience to wait through that process and then go in that graduated manner? Elected governments, I'm sorry to say, don't work in that manner. If there is some evidence, that could be factored in, but if you ask a government to wait for 3 years before they can scale up a program, I mean, probably I will lose my job. So I just can't, assess it. Now, insofar as the RSBY is concerned, now that was a total spending of 800 crores. If you put the states together, it was a total spending of about 1,200, 1,300 crores. In a total spend of 4.5 lakh crores on health, what impact do you want to see on that? I mean, it was you see, and that is the point. We just do something because, there is, a scheme to be announced. We announce it. It's a very low funded scheme. What impact do you see? On the other hand, NHM, we did about 30,000 crores per year for the last 12, 13 years. And it would be, I think, uncharitable to say that it has not achieved any impact. We are saving about 10 lakh kids more than what we were doing in 2001, 2002, 2005. We are saving more mothers. Well, it could all be because of chance. It may be coincidental that, NHM just ran and all these happened without any contribution for NHM. But I would argue that some of it might also have been because of NHM. It may be difficult to separate the cause and effect. It may also have been because, in general, the literacy levels among the females were rising. We did almost universal enrollment under the SSA program. It may also be because we had the huge rural connectivity program. People could reach facilities faster. But it could not be an accident that the institutional delivery jumped up from 38% to 78, 79%. It could not be accidental that the C-section rates, not only in the public sector, but also in the private sector, went up significantly. It is that people are now able to access health services better. And some of it may have happened because of other things as well. But maternal mortality, I mean, unless you have health services, how do you save the mothers? And you are saving significantly more number of mothers and children than what you were doing 10 years back. I mean, it may be because of chance, but it may also partly be attributed to NHM. At least that is the least I can say about that. About the ultimate model, sir. It is difficult to venture a guess what the ultimate model will be. India will find its own path, but it is definitely not headed the US model, where it is fragmented risk pools, multiple payers, without any standardization in terms of costs, fee-for-service payment model. We are not heading that way. That much is certain. But what we are heading towards is, as you said, partially, at least the primary care part will be provided by the government. That much is also almost clear. The secondary and tertiary would have both public and private people competing with the government eventually upping the budgets and hopefully by becoming a larger payer, be able to control the behaviors better. Regulation would be required and regulatory capacity needs to be developed. But in the current scenario, I think the better way is to influence behaviors by becoming a payer rather than becoming a regulator at this point in time. Maybe I can respond more if you want me to, or I have.
Time-wise.
I'm okay. I mean, as long as you say that I have time. As long as you say.
Take 1 or 2 minutes.
There were issues. Then this issue about compulsion. So on fortification, I totally agree with you. I think that is a low cost, high return endeavor. And what we are trying to now do, again, it's the issue about the state capacity and the governance capacity to ensure quality around that. So for far too long, we had no standards. Now the standards have been defined. The first step, what we are trying to do is to get the midday meal scheme, which targets at the children and the adolescents, to try and see the oil that is used in the midday meal scheme is fortified, the salt that is used is fortified, and the flour that is used is fortified. Rice, although again, rice in principle there is no objection. The cost is also not that big a problem. It's the quality control part which is the real worry, because the FCI at the scale of operations that they do, the fortification can only happen at the level of the miller. To ensure a quality control, and it is like in a 100 kg thing, this fortified thing would be 1 kg. So it could easily pass off unless you have real quality control measure built into it to make sure that it reaches the FCI go downs in the fortified condition. And that really is a challenge, and we are working in terms of whether we can build the quality. Where we have got support from agencies, we have been able, for instance in Orissa, to do an experiment, and it resulted in immediate drop in the anemia levels, almost 10 to 15% immediate results. The double fortified salt is now going on in Madhya Pradesh, in UP, in many other districts. They are trying to gradually roll out, and our mission is that in the next 1 to 2 years, we try to expand our coverage at least to those districts which we consider as high burden malnutrition districts. And we are trying our level best. Let us see where we reach on the fortification front. I think I will.
Yeah. So I'll just turn over to Abhijit and Jeff for a few minutes.
So, I mean, I think that this, I feel that I'm essentially, I have no choice but to react to this question on impact measurement. So I think there's essentially a tension between the two things you said. One, you said RSBI, small program, what's the impact? That's precisely why that would be a great place to measure impact. And I'm not saying do an RCT. I mean, there's lots of impact evaluations of NREGA, which may not be perfect, but they have used the fact that some districts were brought in, and that's how the government does it in any case. I mean, so there's no particular reason why that could not have been used as an opportunity. I think the point is not to be ideological about it, but I think to think of it as being, that's always the default, and then sometimes you can't do it. And I'm not saying you're right in saying that sometimes there is political compulsions are too strong, but I don't see a reason why RSBI, given that it was not a huge program, could not have been designed to give us some clear learning. And in fact, what we know about insurance does come from RSBI. So I think it was actually a somewhat of a wasted opportunity. Let me say one other thing. I mean, in some sense, on the whether the government should be a payer or not. Again, I feel like something you said, there's a tension there. You know, my experience, and this sort of Jeff said something similar, is that actually the one part of the government health system that works extremely hard is the district hospitals and above. Sometimes even the block hospitals are okay, but anything below, almost no one goes there. And at least that was my experience in UP, in Rajasthan, in West Bengal. It seems very clear that everybody will say, no, I'll just go to the district hospital. So if that's the case, then why not think of the district hospital as a really important, I mean, why not have 6 district hospitals rather than 1? It just seems like there is a sense in which that's where now, especially given that the transport system is much improved, the connectivity is much improved, take advantage of that. Invest in the district hospitals, have many more of them, and I think that's where the public money would get, I think, best leverage. Right now, I feel that relative to what we know, I would say, just in terms of what gets used, district hospital. For the inpatient, 40% of visits are to public facilities and mostly to district hospitals. And that's really is a separate. It's very different from the 2 bottom layers of the government system, which are essentially unused. And I think, given that, I think it's very clear to me that if there's one thing I would have picked within the to spend money right now, I would have picked that because I think it's at least is used, at least we see that there is a enormous excess demand for it. We see people lying outside the district hospitals waiting. I don't see an obvious reason why I would have picked insurance over that. So let me, the second point I wanted to, last point I wanted to make was that a small point, Monica Dasgupta provided the answer. The answer was in her article. The answer happens to be that Tamil Nadu runs a separate core, not run by doctors, of public health professionals. And it was not governance as much as just a professionalization of public and maintenance, not give it to the doctors who do it on the side. I think that was the last point I wanted to make is that I think that there's sort of a, the fact that I think people have hinted at it, but I think it's not just a matter of creating, IT infrastructure. I think you will empanel doctors, but as Ila said, those empaneled doctors are not known for their, part of the reason why you reform the health system is because famous empaneled doctors are among the people that we are most worried about. So the fact that the empanel doesn't seem to me a guarantee that they're not going to extract 5 lakhs per head. I mean, that was a bit the experience at the end of RSBY in Karnataka was that, they tried all of these tricks and they ended up spending every rupee in some districts. And
but what makes you think the Karnataka was not as successful? I think
if
you go and ask any Kannadiga, they are all happy.
They got the money. They shared it.
No.
I think it's a perfectly good thing to get 30,000 rupees. Half of it you get, I get. I think that they are perfectly happy, but I'm not sure we could find other ways to make transfers.
I don't know if that was the case.
I did a little bit of digging on this, so I'll.
Jeff?
Yeah, there are a lot of issues. I'm not sure we can cover them all. First, I want to second Abhijit's emphasis on the hospitals, not necessarily because it's just a revealed demand, but which is why the rates of public use are so much higher, is that you just can't afford a private stay. I mean, it's just sort of, that's why public hospitals get so much more. And I think a better model for expanding a system would be, since you can monitor doctors in one building much more easily than this spread out system, you can at least improve on the absentee rates, maybe, we don't know. And then the evolution might be, if they feel that too many people are coming to them that could have been dealt with elsewhere, then let the hospital manage some satellites or something to keep things cheaper. That's the only wrinkle. On the effects of National Rural Health Mission, though, I don't know. The only things that I can think of is there was one study of JSY, which was one small part of the system. It was Manoj Mohanan and Grant Miller, and they found that, yes, indeed, lots and lots of women gave birth in modern facilities, and there wasn't an iota of movement in maternal or infant mortality. Now, how is that possible? One possibility is the WHO has always been wrong, which is one thing I'd be willing to accept just off the top of my head, but that modern facilities really weren't as important as they thought. That's one possibility. The other one is, you mentioned the rate of cesareans. A lot of people are very concerned about the increase in the rate of cesareans. There's sort of a optimal amount and probably less than is now.
Yeah, that's not a good indicator at all.
At all, right. And in fact, this is pure speculation, this is based on some data I looked at in Chennai, was the increase of women coming to modern facilities caused the peak load problem for a lot of hospitals. Pregnancies are 9 months, but not 9 months to the day. And so one of the ways that facilities could cope would be to schedule deliveries. Well, how do you schedule a delivery? the only way you can schedule a delivery is with a cesarean section, whether it's necessary or not. And while people might be happy with 4 or 5 people in a ward, they're not so happy with 2 or 3 women in a bed. And open wounds, women that close to each other, probably not a good thing. And I would like to know where you're getting your reinfection rate data. The other broad thing is I had some students that they were undergraduates. It was probably not well done. I don't want to push this too hard. But looked at the 2005 versus the 2015 NFHS. There were lots and lots of correlations, just with standard of living and education and blah, 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 and nothing between 2005 2015 that was not captured by all the usual suspects. So correlation is not causation, but lack of correlation isn't particularly strong evidence either. So it doesn't look really good for that. Indira, actually, there's a lot of things that overlap with the development of systems, so let me move there. Actually, there's lots of different ways that different countries have dealt with this very complicated, it's a genuinely complicated problem, and a much wider variety than you mentioned, Vijay. So Finland has everybody under public employment, just like here, except, well, 2 things. First of all, Finland is 4 million people, so what's that, Midnapore? I don't know. So it's tiny. It's number 1 in Transparency International's most honest everybody, and which is not exactly India's problem. And in Finland, they're employees of the local government because in Finland, they did not think that the national government had enough administrative capacity to actually monitor doctors at a national level. Finland, with 4 million people and the most honest people in the world, can't do it at national level. They needed to do it locally. That's one, but it works fine. It works fine. Sweden, also public employees until Stockholm, which has 10 million people, so it's 3 districts, decided that they weren't getting good enough care, and they split it so there'd be some competition. So in Sweden, which isn't that much less honest, and not that much less administratively capable, also needed to introduce something different. So I don't know about this designing systems from scratch. Most of them sort of evolved somehow or other. Many of them are okay. Most rich countries' systems are okay, but they're quite different. And I'm not sure whether it's such a hot idea to know where you're absolutely going to go as opposed to making marginal improvements and fixing things along the way, which is why I don't want to say everybody should have these hospitals. I think that might be a good way to go, but not necessarily the final. Yeah, okay. Administrative capacity in general is over my pay grade. And Thailand has had a reasonably good system for some time, and it is something of a mystery. The NIPFP conference a couple years ago had a representative of Thailand that was talking about the expansion to the not as poor people. And then the question was, so how come it works? And he didn't know why, in general, this works. But there's lots of models out there that could be tried, but I think it has to be a tattoo model.
Predominantly public, 70% of it is public.
No, that's right, and it generally works. So I can't really say. Another paper by Monica, probably not as replicable, is she also found that countries that were ex-Japanese colonies did much better because but you probably don't want to go that direction, right?
I think we also have an excess of private enterprise. Kenya also has better healthcare than we do. I mean, you take a country which you wouldn't imagine, but you look at their any outcome, they do better than us.
Yeah, so I'll just wrap up with, I guess, just one set of comments. And it was interesting that, Alok ji himself mentioned that this could be NHM, or it could be a bunch of other things. And Jeff kind of said, when you put in a bunch of other things, there's nothing there, right? Like, I mean, with these programs. Now, but one very interesting point is roads, and I just saw a paper a few days ago at this conference at ISB, and it's a very nice paper using the PMGSY and the fact that you have a discontinuity in the construction of roads that actually finds that the construction of roads did meaningfully correlate with substantial improvements in maternal, institutional deliveries and a whole bunch of things. I think, so the reason I mentioned this is for two things, is that in general, when we think about access, the way the government thinks about access, whether it's health or education, has always been about how do I put a school or put a clinic within like a kilometer, a certain distance of where the people are. But there is this fundamental trade-off between access and scale, which typically does not show up in these discussions at all. So the extreme example in education is Madhya Pradesh now has over 100,000 primary schools, with about 8,000 of them actually having literally 0 kids, okay? Like, I mean, and many of them have under 20 kids. And so I think some states like Rajasthan have started kind of going back and consolidating. But I think health is an interesting thing, right? Because health, you can do this consolidation a little bit more easier than education, because the distance elasticity of willingness to travel for health is lower than education, because education, the kids are younger and they have to travel every day. Whereas health, people are in fact willing to travel. So I think the combination of constructing roads and what we're seeing from district hospitals suggests that, there's economies of scale, both in terms of the fixed cost, in terms of management and supervision, in terms of complementarity across specializations. So I think that is something to keep in mind, as in it's a much broader point that the most effective thing to do for health may not be sitting in health at all. It may be sitting in air regulation, it may be sitting in water and sanitation, it may be sitting in road construction, and that what you need to do for health is not necessarily build like large curative infrastructure, but take the role as a payer and payer. But no, exactly, but the highest return on public spending could be higher. And then the last point, just on research and evaluation, let me again make a plug again that, this study I just talked about was not an RCT. And, most good work in the US, uses state level variation in policies and uses administrative data. So, and I think the good news in India is, with 30 states, we just have enough to kind of satisfy the clustering gurus, that you have enough variation. And this ISB conference I was at, I was pleasantly surprised to see how many young Indian economists are working on evaluating policies. There was this very nice paper looking at the impact of cattle slaughter bans in terms of impact on anemia, because that is a source of iron. And again, using state level variation, using a combination of NSS for prices, using NFHS for healthcare outcomes. So there's a lot more that can be done, even without a government like choosing to randomize. I think you just need high quality outcome data, high quality panel data, high quality just general statistical infrastructure that you can then combine with kind of quasi-experimental identification. So yeah, I'll just stop there. And that being said, experiments are still possible, because as we've shown in Andhra Pradesh, Madhya Pradesh, multiple states, now in Jharkhand, we've been able to do RCTs covering 10, 20 million people, partly because even when the government wants to scale up, even when the Prime Minister says, I want this thing, it's not going to happen nationwide on day one. There is still a staggering process, and if done properly, it's possible to layer high quality research on that. So let me bring the panel to a conclusion. Thank all our panelists for their insightful comments, and take a break as we get ready for Avinash's IPF lecture. So